Good afternoon, students. Welcome to the review for our respiratory and cardiac units. I hope you guys are studying hard. Once again, are matching up our book with our chapters. We have chapters 12 through 14, which goes over our respiratory unit. In chapter 12, I talked a lot about the structure of our nasal passageways. We have all these different sinuses within our face and our bony structures. Those sinuses can become infected, filled with mucus. You can have pressure, discomfort, pain. Remember, with those sinuses, we have the sinuses here, along up here. When some of the sinuses become clogged, our patients may talk about pain that's in their upper teeth. So that's with sinusitis. And remember the structure of the mouth that connects to, so when we chew something, that goes, when we swallow it, normally it goes down in the mouth, through the pharynx, into the esophagus, and then into the stomach. Now with laryngitis, or knowing where the larynx is, that's what connects the mouth. The epiglottis covers that larynx so that food and fluids don't get aspirated into the lungs. So it goes from the mouth. The nose also connects in the back of the throat. Then we got the epiglottis that covers the larynx. The larynx connects the trachea to our bronchioles and then to our upper lung area. So anytime we have something that is infected, or whether it's bacterial or viral, a lot of those, whether it's laryngitis or sinusitis or pharyngitis, or even some of the upper respiratory disorders, the patients are going to present with cough, fever, maybe a headache. They're going to be fatigued, sore throat, and along with tonsillitis too. So with tonsillitis, we got our two tonsils on the side there. Sometimes those can become infected. There might be like a whitish or yellowish discharge on the tonsils. And with the tonsils, it's important to note that there's adenoids that are connected to the tonsils, and typically nowadays they don't do tonsillectomies as frequently as they used to. Now they'll first start with that, taking the adenoids out, and then maybe they'll put tubes in the ears for our younger folks, or even our teenagers and adults. But one of the things that I definitely want you guys to remember, that I talked about in lecture, with removing the tonsils with a tonsillectomy, the patient is going to have a sore throat. We encourage them to have soft, bland foods that are easy to swallow. One of the things that we want to look for, especially directly right after the surgery, is when the patient wakes up, are they swallowing frequently? And they could be swallowing, because of the discomfort, or the other risk is that they could be swallowing because they might be bleeding. Maybe there was an area that wasn't closed, or an area that was nicked, and now it's bleeding from that surgical site. So we definitely want to look inside. So one of the first things, if we see a patient who is frequently swallowing, if they don't complain of pain, even if they don't complain of pain, one of the first assessments we're going to do is actually look inside their mouth and make sure that their airway is clear. That's one of the first things that we want to do. And then so we observe to see if there's any extra bleeding back there. And if there is, we definitely want to call the healthcare provider and make them aware of that, because we don't want that to bleed for too long. One of the other things, with the treatment and care of anyone who has inflammation of their throat, one of our first things that we want to teach them is that you can gargle with warm water, and that's with any throat discomfort. So they can gargle with warm water. They definitely want to have easy to chew stuff. And then also we want to be able to humidify their air. And like I said, during the wintertime, it's very dry indoors. We don't open the windows a lot, especially where it's cold. We have the furnace going more frequently, so that tends to dry out the air, make it warmer, and then that can irritate the lining of the throat, especially if someone has a virus or a bacteria that's going in there. Now, looking a little further along the line of surgery in the neck area, anytime for people who have to have a tracheostomy, and that is where they put in an artificial hole in the throat. Typically, it's for people who had some cancer of the throat, usually due to smoking or environmental exposure. Another risk, big risk for developing cancer of the throat is drinking, alcohol and smoking. Those kind of go hand in hand with the development of cancer of the throat. But for people who do get a tracheostomy, especially if somebody is new to getting a tracheostomy, they're going to be having some issues with their appearance. And when they initially get that tracheostomy, it might be kind of hard for them to talk. So if you want to have therapeutic communication with a new trach patient, you definitely want to explore their feelings of their new appearance, see how they're feeling. And they might not be able to talk to you verbally. Hopefully they have good hearing and they can still listen to you. But one of the ways that we can get a new trach patient to open up to us is, give them a pen, provide them with writing materials, and be able to communicate by writing and being able to explore their feelings through their writing. And some of our trach patients, as they heal, they can regain some ability to speak. So definitely want you to know that even though a patient has a trach and they can't talk initially, have them explore their feelings by writing things down. When we have, and I said this several times, when do we treat an infection of the respiratory system? The respiratory system includes the lungs, the throat, the upper mouth, all those passageways that connect our mouth to our lungs. So any of those can become infected. And I taught you guys that viral infections we don't want to be treating with antibiotics. It's the bacterial infections that we definitely want to treat with antibiotics. Sometimes, however, when a patient develops a viral infection, bacteria can be opportunistic enough, sneak in, and now the patient has a secondary infection that may be bacterial in origin. Patients are more susceptible to getting a bacterial or secondary infection in the presence of an initial primary viral infection. So we definitely want to teach our patients, we only treat it when it's bacterial with antibiotics. One of the things that I talked about with these respiratory diseases, whether it's obstructive or restrictive airway, remember our two categories of respiratory infections were the restrictive ones, and that had to deal with structural abnormalities of the spine, such as kyphosis, scoliosis, the pneumothorax, where they actually, the lung tissue is injured, that can change the structure of it, so that becomes a restrictive, under the restrictive category. Our obstructive category of upper respiratory infections, and that can include lower now too. The obstructive is our emphysema, our chronic bronchitis, and asthma. So, but with any of those, you can have the symptom of coughing, that fever, that temperature, whether it's bacterial or viral. One of the things that I wanted to mention with chronic obstructive pulmonary disorder, COPD, is that we definitely want to be able to catch on to early symptoms of their COPD worsening. And there's a kind of a big symptom that I definitely want to touch on, and that is the distended neck veins. Anytime that we have a patient with COPD and it appears that their neck veins are becoming more and more distended, that is definitely something that we want to notify the healthcare provider of immediately. Those neck veins can actually start to bulge as the disease starts to worsen, and during like an acute exacerbation, those neck veins can become very distended, and that is a bad sign. We definitely want to report to the healthcare provider. With our COPD patients, you'll notice that sometimes it's easier for them to breathe when they're kind of hunched over in a tripod position. It may look like them sitting bent over a table. As long as they're not in any distress and their vital signs are still normal and they're not really complaining to you that they're feeling any differently, sitting over that table is something that's normal for them. So don't be too alarmed if you come in the room and find the patient, hunched over sitting in that tripod position. It allows them to breathe a bit easier. So make sure you still assess them, check in with them, make sure they're okay. The one thing that we want to look for is that distended neck vein. When we're looking at when we're gathering a patient's history, especially those with laryngeal cancer, an older adult who has a family history of laryngeal cancer, what are some of the things that we should ask them? And we definitely want to know about, what kind of job did you have when, were you exposed to pesticides, or were you like a carpenter where you were around a lot of dust particles and wood chippings? Our carpenters are frequently around, they're sanding wood and making it fine, and over years and years of exposure to that at their job, the lungs, you can actually inhale those dust particles, those wood particles, or those pesticides, or whatever occupation that they're working with. So another high hazard job is our construction workers, and the ones that are working on our roads all summer long. When I drive by and they're putting down sometimes they're actually like grinding cement dust, and you can just feel that, I drive right through, but you can feel like cement in the air. Or when they're doing blacktop, when they're laying that layer of blacktop and using that tar, I go by for 30 seconds and it's like, whoa, I can already feel that. But imagine being exposed to that for 8 to 10 hours a day all summer long. So our construction workers are at high risk of developing laryngeal cancer. Our carpenters, our construction workers, and then of course our people who are dealing with either paints or pesticides, who are around that a lot. We definitely want to know about their history of smoking. Did they drink alcohol? When we ask about smoking, we want to know how long and how much. So we definitely want to assess that, especially in someone who may have a family history of laryngeal cancer. Another occupation that I talked about in class that is highly contributes to lung disease is the coal miner. I talked a little bit about the black lung, and our miners who are exposed to, especially deep down inside of a mine. Sometimes it's deep underground. It's not highly ventilated, so they can be inhaling, particles from the dirt, the rocks that they're chipping away at. And then, of course, if it's a coal mine or something, it's, they're dealing with that, the byproduct of the coal. It's small particles in the air that can build up in the lungs. What else do we want to know here? When we talk about our patients who have asthma, one of the things that we can use to see how far along the disease is progressing and to see how effective their medication is, their bronchodilators, are people with asthma. We want to teach them that they'll usually get 2 inhalers. One will be a bronchodilator and the other will be a corticosteroid. So you want to teach our patients that they use the bronchodilator inhaler first. Use that one first. That helps open up the bronchioles. It'll so that air can move more effectively in there. And then we teach them to wait a couple minutes and then take their corticosteroid. To be able to monitor how effective the bronchodilator therapy is, we use something that's called a peak flow meter. And the patient usually uses this. They put it in their mouth, and they're taught to take a nice slow deep breath in through their nose, and then they're taught to blow out very rapidly, very forcefully, as much as they can into this apparatus, the peak flow meter. And we teach them to do that before they take their bronchodilator and then afterwards. And if the bronchodilator is effective, they'll be able to have a much higher reading after they take that inhaler. So we teach them to do it before they take their medicine. Breathe deep, and then blow hard on the exhale with your mouth. And then we teach them to do that afterwards, and then see if there's a difference, to see how effective their medication is, their inhaler that they're taking. So that's the peak flow rate, the peak flow meter. Let's see, where are we here? When they're using that peak flow meter, we want to teach them that they're sitting up. We don't want them laying flat when they're doing the flow meter. When they're standing up or sitting up, it allows the lungs to fully expand more. We definitely want them to blow out hard and fast on the exhalation into this peak flow meter. So when we talk about emphysema, remember, emphysema is one of our obstructive lung disorders. Someone who is in an acute exacerbation of their emphysema, their pulse ox may start to drop. We want to teach our people with emphysema, how to do pursed lip breathing. And with pursed lip breathing, our people with emphysema, sometimes it's difficult for them to get air in and out of their lungs. So when we teach them how to do this pursed lip breathing, it looks like this. It's on the expiration. When they're exhaling, we want to teach them to put their lips like this into a pursed lip breathing. So breathe in. This forces the exhalation to have a little bit more pressure behind it and allows them to get that CO2 out of their lungs. That's one of the first things that we want to teach our patients who have emphysema and present to the emergency room with severe dyspnea. Their pulse ox may be low, so we definitely want to teach them first. They're probably going to be anxious, so hopefully we can teach them how to do that pursed lip breathing, and it might be that their pulse ox may come up with, and you don't even need oxygen just by teaching them that pursed lip breathing. Also, our people with emphysema, they tend to have a cough, they have difficulty breathing. They also start to develop what we call a barrel chest, and it has to do with that they're always exhaling. Maybe they're not exhaling properly, and eventually over time it starts to have an effect on their diaphragm, and it pulls their chest into like this barrel chest appearance. So that is one of the trademarks of advancing emphysema. Going over our different respiration patterns, I know we did a little bit in class. So some of the terms that I want you to know: eupnea, EUPNEA, that is normal breathing. That should the normal rate and the normal rhythm. Tachypnea is where the respirations are up, they're above 20. Bradypnea, that's where the respirations are low, they're below 12. Remember, our normal respirations are 12 to 20. Above 20, tachypnea. Below 12, bradypnea. Kussmaul's respirations are those very fast, deep respirations. There's no expiratory pause, usually seen in our diabetic patients who may be having diabetic acidosis or coma. The Biot's respiration is what you see. They're fast, deep, irregular respirations with periods of apnea. Apnea is absence of breath. That is seen in our patients with increased intracranial pressure. So someone who has too much pressure in their head, they may have these Biot's respirations where it's very fast, deep, irregular, has periods of apnea where it looks like they may not be breathing at all. Our Cheyenne-Stokes respirations, that's where the respirations become faster, deeper, then slower, shallower with periods of apnea. That's seen in patients with coma, resulting from disorders affecting the central nervous system. So it looks like Cheyenne-Stokes and Kussmaul's can be in our patients with a coma. Our Biot's respirations is for those with the increased intracranial pressure. Apnea is the absence of breathing. And then apneustic, that's prolonged inhalation with a pause at the peak inspiration, then a short exhalation followed by short periods of apnea. That can be seen when there's damage to the respiratory centers in the brain. So our patients with emphysema, they typically don't have Biot's, they don't have Kussmaul's, they don't have Cheyenne-Stokes, they may have tachypnea. They may have very fast increased respirations. Going on, what are we on here? We always want to teach about, lifestyle modifications, whether it has to do with bringing the blood pressure down. Typically, our patients who are in the early stages of being diagnosed with hypertension, specifically those with pre-hypertension, we teach them lifestyle modifications first. So, go join a gym, try and change your dietary habits. Managing stress, of course, managing stress is always huge. So those are important, for many of the early stages of hypertension, and also someone who may be diagnosed with a chronic lung disorder. We want to teach them to modify their smoking habits. We want them to stop smoking, stop drinking, and modify that lifestyle and try and incorporate more exercise, more stress reduction techniques. When we start to, someone who does have the flu, influenza, remember we don't treat with antibiotics, we can treat it with antivirals though. Important to teach these patients that to take these antivirals exactly as the provider orders it. Even when they do start an antiviral, they're still contagious for a couple days initially. They can actually be more susceptible to other infections when they're taking an antiviral. And we want to teach them, you may want to avoid crowds until your fever has come down. So you definitely, initially, even though you're started on an antiviral the first day or two, you still want to hang back a little before you start to return to your normal activities, because you can still be contagious even, when you first start that antiviral. Going on to tuberculosis, we talked a bit about tuberculosis. A patient who has been actively diagnosed with it, remember if we do a TB skin test on their skin, the induration is that raised area. The raised area is what we're measuring. And for someone from America, if that is bigger than 10 millimeters, then we definitely are going to be considering them positive for TB. So if someone does have TB, we use the quantiferon gold standard. That is a blood test that sees If they do have TB, we can use an x-ray. If a patient has active TB and they're in the hospital, they're going to have to be put in that negative pressure air room. And then the staff who come in will have to be fitted for the N95 respirator mask or the HEPA filter. But most of our people who do have tuberculosis, they can be treated in an outpatient setting. So we have to teach them that they're going to be on this medication for 6 to 9 months, and compliance is a huge issue because we don't want them spreading the tuberculosis around to the community. So we want to teach them about compliance with their medication, teach them about the side effects of the medication. We definitely want them to, one of the things with tuberculosis, it likes to hang out in dark, damp areas. So we definitely, if the patient is able to, we want them, if they're at home and they're being treated outpatient with tuberculosis, we want to teach them to have a well-ventilated house, try and get some sunlight in there. They don't have to install a negative pressure air room in their own home. So keep that in mind with our patients who are outpatient out in the community and they have TB. Let's see, where are we on now? When we're talking to our patients now, getting into heart failure, as we start to remember heart failure, we want to be teaching our patients that they have to balance their rest with activity. Whether they're left or right-sided heart failure, they're going to be getting very tired and short of breath with activity. So we want them balancing their rest with activity. We don't want them adding any extra salt to their meals. So we want to tell them to avoid adding extra salt to their meals. We want to teach them to eat small, nutrient-dense meals. So rather than eating, say for example, 2 large meals a day, our people with heart failure, we want them avoiding having large meals. So we want to teach them to have those small, nutrient-dense meals. Maybe spread that out a little more throughout the day. So when we're looking at peripheral artery disease, remember, the periphery is outside the heart, outside of the brain. Usually with peripheral artery disease, it manifests in the legs. So someone who does have peripheral artery disease of the lower extremities, we want to teach them to avoid crossing their legs. We want to teach them to avoid getting too cold. We want to teach them to keep warm, keep the circulation going. So they should avoid cold, try to avoid coolness. We do want to teach them that if they can walk, they should. Walking helps promote circulation in the legs, so that's great to enhance blood flow. We want to teach them to avoid constrictive clothing. We don't want clothing that's too tight on them because their flow to their legs is already decreased. We don't want to increase. We don't want to increase the decrease in flow. So if a patient would cross their legs, that can actually cut off circulation further. If they're wearing tight constrictive clothes, that can actually cut off circulation further. We want to try and improve blood flow as much as possible. So we teach them they can walk. Walking is great to enhance that blood flow. Stay away from cold places, especially with Raynaud's too. When I talked about Raynaud's disease, that is where they typically have spasms in their smooth lining of their vessels, and it actually cuts off circulation to their fingers or their toes possibly. So someone with Raynaud's may show up as having discoloration of their fingertips. We teach them that they should avoid coldness also, so that when they go outside during winter, we'll teach them to wear warm clothing, definitely double glove if they have to, because the cold weather can actually exacerbate that occlusion that's already there, and then it can actually cut off circulation, leading to necrosis of the fingertips. Talking about the non-modifiable risk factors in clients with heart disease, we know that we can't modify what we were born as. We can't modify our race, our genetics. We can't modify our age. Some of the things that we can modify to help reduce our risk for developing heart disease is, we can modify if we're smoking or not, how much we're smoking. We can modify our weight to a certain extent by increasing exercise, staying away from a sedentary lifestyle, eating healthier. So that's non-modifiable, and then modifiable risk factors for heart disease. What else here? New pain. One of the things, remember I talked about with signs and symptoms of a heart attack, especially in our women, we want to teach them that new pain in the jaw, back, and shoulder, along with shortness of breath and nausea, can be a sign of an MI. So we definitely want to update the healthcare provider as soon as possible. When we're talking about left-sided heart failure, remember, left side of the heart is over here. The left atrium receives oxygenated blood from the lungs. So many times, one of the signs and symptoms that we'll notice with someone with left-sided heart failure is that they'll have cough and crackles as the fluid backs up in their lungs. Now, versus right-sided heart failure, we remember that right-sided heart failure, the right atrium receives blood from the upper and lower vena cava. When that right side of the heart starts to fail, fluid tends to back up. It can back up in the neck. It can also back up typically from the chest down. So they may have hepatomegaly, that is enlargement of the liver due to the backup of fluids. They may have swelling in their legs, their feet, their ankles, edema. So that's for the signs and symptoms of right-sided heart failure. Left-sided, I said you'll hear the fluid back up in the lungs. Right-sided heart failure, the fluid tends to back up in the body. Someone who does have heart failure, we definitely want to teach them to weigh themselves first thing upon awakening. It's best to do it, in the morning, right when you wake up. Make a habit of it so that you're doing it every day at the same time every day. Maybe you wake up an hour later than you normally do. Still weigh yourself first thing in the morning so that you have a baseline of your weight. Because our patients with heart failure, one of the ways to see if the heart is failing even more is that they'll gain weight, and they'll gain 2 to 3 pounds in a day or two. We definitely want them reporting that to us. So very important that someone who's at home, or even if they're in your long-term care facility, try and weigh them first thing in the morning upon awakening, even before they take their med, before they eat. When we're teaching someone with how to correctly use their, someone with sinusitis, someone who has frequent congestion of their sinuses, we want to teach them to be using their mists or their sprays as ordered. One of the things that can happen is that rebound congestion with people who overuse the nasal spray, and then it actually ends up getting worse. The medication isn't as effective. So very good that we're teaching our clients to use those medications directly as prescribed. Let's see what else here. That looks like we're getting pretty close to the end here. Our clients with coronary artery disease, we definitely want to teach them. Remember, coronary artery disease is the blockage of the blood vessels that supply the heart's muscle with blood and oxygen and nutrients. When those get clogged, that can lead to angina. One of the big risk factors of our people for coronary artery disease, of course, is advancing age and a history of atherosclerosis. Remember, atherosclerosis is the buildup of plaque within the artery walls, and the artery walls become narrower and narrower. That impedes upon the flow of oxygen, blood, and nutrients, and when that is in the coronary arteries, that can definitely affect the heart. So what are some of the symptoms that someone with coronary artery disease might be experiencing? They'll have that angina pectoris, chest pain. They'll have dyspnea, and then increasing weakness. And then we teach those clients that if they have nitro, they can take their nitro, take the first dose, wait 5 minutes, assess and see if the chest pain has gone away or not. If the chest pain hasn't gone away, we teach them, if they're at home, take full-strength aspirin, which is 325 milligrams. Then they should be calling 911. They can take another nitro dose, and then hopefully the ambulance will show up there before they have to take that third. But if a patient is in your facility and they have nitro ordered, you can give that nitro up to 3 doses, wait 5 minutes apart. If by that third dose it's not relieved, we're definitely calling the healthcare provider and hopefully sending them to the emergency room. Whenever you're talking to clients therapeutic communication, whether it's verbally or writing with a patient who has a trach, they can't talk, we still encourage them to write down their feelings, get them to talk more to us, communicate more to us, explore their feelings more with us. One of the most common signs and symptoms of elevated BP, remember we talked about high blood pressure as the silent killer, because you typically don't experience symptoms until your blood pressure's getting more up there. But one of the most common signs of hypertension is a headache. When we're talking about low sodium diet changes, we definitely want to teach them to avoid high sodium foods such as, cheeses. Cheeses can be high sodium. Of course, all of our wonderful snacks. The fresher the food, the less preservatives in it, the better. Usually the lower the sodium content is. So, fresh spinach, brown rice, if you're not adding anything to it, pasta, those can be healthy choices that are low in sodium. Remember when we talk about varicose veins is where the valves in your venous system either don't close all the way or they're leaky, and blood tends to back up thanks to gravity, and then the veins in the legs become bulging and thicker. When we're explaining that to a client, we definitely want to try and say it in non-medical terminology terms. So, try to avoid using big fancy medical terminology when we're teaching our patients. Our patients with a history of varicose veins, one of the first things that we want to try to start with is having them use some compression stockings. And typically compression stockings will help prevent the veins from bulging further. It'll help relieve some of the discomfort. It'll help keep things nice and tight and moving around within their leg. So that's usually a good start for our patients with varicose veins. Usually surgical intervention isn't necessary unless, the patient has extreme pain, or usually though people, when they get varicose vein surgery, it's because they don't like the appearance of them. So we definitely want to teach our patients about the side effect, what can happen with the risk with surgery. And then, it's up to the doctor and us to be able to educate our patient enough to make a decision whether they think taking their veins, stripping their veins out is a good idea just for aesthetic purposes. But we always want to teach, good to start with stockings first. If the stockings don't help relieve the pain, then they can discuss further options. But start with those compression stockings first. Our people with a deep vein thrombosis, we want to teach them that If you can walk and the pain's not too bad, good idea to get up, walk around. We teach them that they may have a decreased sensation in that leg, so definitely have someone with you when you're walking, because if all of a sudden the feeling in your leg goes out and you're walking, you know, that puts them in a predicament. So we do teach our patients with DVT they can walk. Just be careful of that decreased sensation. Have someone with you there for safety purposes, maybe someone with a wheelchair or a walker. Our patients with DVTs, we do teach them that we can use the SCDs in the hospital as long as the doctor's okay with it. Those don't squeeze the leg enough to dislodge the clot. One thing that we do teach the patient to avoid is to deeply massage or palpate that area. So if a patient says something to the effect of, you know, when my leg hurts, say the patient is diagnosed with a DVT, and then the patient says to you, when my leg hurts, I like to massage it deeply. We teach them, no, don't do that. You don't want to be massaging the affected extremity too deeply, because you can actually dislodge that clot, putting it in the lungs. So that's bad. Are people with who do develop embolic occlusions of the lower extremities, and if they have peripheral artery disease, there's a 5 P's that we can teach them about how to recognize whether that occlusion is getting to the point where it's going to start really affecting everything that's occluded and down. So we teach them to report pain, you know, increased pain to that area, pulselessness. If you can't feel a pulse on that affected extremity, that could be a sign that it's developing an embolic occlusion. We teach about pallor, paralysis, and paresthesia. Paresthesia is where the patient just reports numbness and tingling. Paralysis is where they really can't move that extremity at all. So the signs and symptoms of a developing embolic occlusion, it's paresthesia, pain, paralysis, pulselessness, and pallor. Those are the 5 P's that I want you to know with our patients with peripheral artery disease. We want to make sure that we're monitoring that affected extremity and making sure that it's not further occluded, because it can get to a point where it's so occluded that now they have to cut that leg off, and that's one thing we want to try and prevent in our patients. So one last thing, in my experience, sometimes I never liked to use the electric blood pressure cuffs. It seems like many times my colleagues who were using those, sometimes they get crazy readings, you know, like 220 over, you know, 140. If you ever get a reading and you're using an electronic wrist cuff, if you get some crazy reading, you definitely want to take a manual blood pressure cuff. Take that manual blood pressure cuff, get your stethoscope out, and take their blood pressure manually. You don't want to be calling the healthcare provider just based off of one reading, and you were using an electronic wrist cuff. I find that it's a lot more accurate to use the manual cuff with a stethoscope. So if you get a crazy reading with a wrist cuff, definitely get a manual and take that, and then if it's still that high, you definitely want to call the provider first. So I hope this video was helpful. We're going into 45 minutes here, so it was a bit long, but definitely want to make sure that you guys are well prepared for the test. So it's chapters 12 through 14, that's respiratory, and then chapters 17 through 20 is the cardiac. So I'll see you all next week. Good luck at the test.